Thank you. It's a pleasure to be here. I'm going to talk about evaluation results in the program we've been implementing at 18 hospitals in Los Angeles in collaboration with the Corporation for Supportive Housing. These, on this map, you can see the location of these hospitals. FUSE stands for Frequent User System Engagement, and SIF is Social Innovation Fund. And with those funds, we've implemented a program for very high-need homeless folks based on several pieces of research. The upper left is research we carried out in collaboration with Los Angeles County that linked records for a representative sample of about 9,000 homeless people, including health records. And so I'm going to talk a little bit about material out of that. The report on the far right is an evaluation report on the first 163 people who were served. So I'm going to talk a bit about these. So when we did the cost analysis, we linked records for these homeless folks across all of these county departments. And then we took this homeless population and we divided them into 10 equal groups based on their cost. So we divided them into deciles, and this decile on the far right, the 10th decile, drew a lot of attention because folks in that group accounted for over half of all of the public costs for homelessness, and all of the blue shades that you see there are healthcare costs. So inpatient hospitalization is a lot. The green that you see on the top of that right bar is mental health incarceration and medical incarceration. So costs highly concentrated in this group of frequent users. And the characteristic of these folks, what distinguishes them, is that they have recurring crises in their lives that get resolved either in a hospital or a jail at considerable public cost. So there was significant interest in, well, who are these folks? How do we find them? Why don't we do something about this? And another piece of our work looked at costs for a matched comparison group of people who had been placed in permanent, thanks so much. Thank you. People in permanent supportive housing. So what we saw was a remarkable decline in costs for this group who had these continuing crises in their lives when they were in permanently affordable housing with supportive services. This enabled them to get continuity of health care at clinics rather than hospitals. It reduced the anxiety of being on a sidewalk, being subject to the weather, being subject to predators. So when people were stabilized, costs go way, way down. And so there was interest in, well, how do we find this population? How do we capture these potential cost savings from housing them? This is kind of the low-hanging fruit, the 10th decile. And so we began to look into it. And there are a number of factors that have some predictive strength, but none of them by themselves are a precise tool for targeting this population. The strongest predictor was jail mental health incarceration, followed by being a hospital inpatient, followed by being being treated for a psychosis. But none of these by themselves had enough predictive power to zero in on the population. And the reason for that is there are a lot of different paths into the the conditions of distress and system engagement that lead people again and again into hospitals and jails. You can be a middle-aged woman who has diabetes and a respiratory disorder and a bipolar disorder. You can be a young man who's schizophrenic and has drug dependency and acts out floridly in public. You can be a middle-aged man who's just depressed and has injuries. You can be an older man with psychosis and drug dependence. There's a lot of different paths. And so finding a way that identified these diverse people with the common problem of using hospitals and jails extensively was a complex problem. Oops, wrong direction. So we developed tools to work within the context of looking for a population that was homeless, looking for a population that had been treated at a hospital in the last couple of years, and avoiding showstoppers to getting affordable housing. So if you're not a documented immigrant, that's a showstopper. If you're on parole for a violent crime, that's a showstopper. Having convictions for arson, running a meth lab, or being a registered sex offender are showstoppers. Also being so disabled that you can't live independently is a showstopper. So within the framework of eliminating these groups who were not, it was not feasible to place in permanent supportive housing, we developed a triage screening tool that's being used at these 18 hospitals. And it draws on a number of pieces of diagnostic information in addition to information about just hospital use. Most of the predictive power comes out of hospital use, and these the diagnostic information adds considerably to the accuracy and makes it it gets it right about 7 out of 8 times in terms of identifying folks in the 10th decile. And we also have in the system the option for a clinical override if a patient doesn't have current levels of hospital usage that put them into the 10th decile but have a diagnosis, for example, being HIV positive, that creates a very high probability of being in the 10th decile. So the process that's used in hospitals for the screening is one that the patient isn't told about the program opportunity to be housed until we know they're eligible. And once we know they're eligible, we try to get everything to happen in about 4 hours. So a hospital social worker will send screening information to a housing navigator who runs the information through a triage tool. If the person is eligible, the social worker asks them if they're interested. If they're interested, the navigator goes to the hospital right away, talks to them, asks if they would like to have housing of their own, takes them from the hospital, puts them immediately in housing, and begins providing a range of social services to them immediately. So the folks who have who are in the 10th decile, the first 163 people, a little over 70% were men, almost half African American. By and large, people with a fair amount of mileage on their bodies, about 48 years old, and living on the streets. About 30% had a recent jail history. Extensive use of hospitals in the past, average of 7 inpatient admissions in the past 24 months, 18 ER admissions, and it's by and large a population with dual and trimorbidities, so substance abuse, mental health, and a chronic physical problem. So part of what we're learning in the project is some of the things that stop us from housing people. So of the people we screened, 80% were in the 10th decile. And out of the total screened population, 58% have been engaged and housed. The things that get in our way are people who we've engaged but have gone missing and we have to find again. Situations where the hospital handoff fails, the person isn't at the hospital when our navigator gets there. 5% of individuals have turned us down. 4% we've engaged but have died. This is a sick population. 3% we've engaged but they've gone to jail, so we're waiting for them to get out. And then there are a variety of issues that keep some individuals from being housed, having drug offenses, being a registered sex offender, not being a documented immigrant. But the good news is that when we engage people and they hang in there with the program, that just about everybody gets housed. Just about everybody who sticks with it, 98% get housed. The difficult news is that it often takes us a very long time. There's an acute shortage of affordable housing in Los Angeles. The health department is doing some wonderful and remarkable things. The Housing Authority is trying very hard to help, but we have an acute shortage of affordable housing. When we looked at actual costs for folks in this population who we've housed out of these pilots, their costs while homeless were about $67,000 a year. Their costs when housed were around $19,000 a year. So for every dollar that we spend navigating and subsidizing housing costs to get them into housing, we save $2 in the first year and then $6 a year in the years that follow. So it's a program with savings that pay for it. Issues that we're encountering are that, first of all, it's very hard to get high quality temporary housing. It's a lot easier to hang on to folks if they have a room of their own to live in. That's expensive, and when you have to wait 6, 8, 12 months for trying to get a Section 8 voucher, it can be very serious. It's hard to hang on to folks, and it's hard to pay those costs. We're trying to improve the handoffs from hospital navigators so that hospitals make a more focused effort to hang on to the person until our navigator gets there and make a warm handoff. We're particularly working now on scaling up and on financial reciprocity from healthcare providers, and I'll talk, that'll be my final slide to talk about that. But making these savings fungible, moving money not spent in a hospital into a context where it can pay for housing is something that everybody is still learning how to do. We're moving to system-based screening rather than person-by-person screening. These are system-based tools, these screening tools, and they require information that's available in hospitals or in jails. So ideally, they are linked to system databases, and that's something we're beginning to do, and bringing it to scale so that the costs are truly visible. Because if you do 100 people, it's hard to find identifiable cost savings in Los Angeles. If you do several thousand people, it does begin to become a visible savings. And so this is the slide I'd like to end with on where we are, which is making the transition under the Affordable Care Act, where now these these high-cost homeless folks have an HMO who's responsible for paying their bills. That HMO has contracts with hospitals, and those hospitals face financial penalties if that patient is admitted repeatedly for the same problem. So there's an interest both on the part of insurers and hospitals to stabilize people and reduce unnecessary hospital use. And so we're moving from screening one at a time as social workers flag people to screening entire patient databases. The first one to do this is Anthem Blue Cross, and we're screening their patient database to flag folks who are eligible. So with that, I thank you, and I'll hand it off to our next presenter.